Thank you very much. Thank you, Isfagan. Thank you, Dr. Malati and Dr. Anshu. And I must thank people who have chosen me. It's a very humbling experience for me. Keeping in mind the three stalwarts who represent this oration, I feel very humble and I feel very, very honored to be here. And like I told Anshu, that this particular oration is not coming from me alone. This oration is coming from my department, from the Department of Pediatric Hepatology, Institute of Liver and Biliary Sciences. We all as a team are taking up this oration together, and it is what we are experiencing, what we are doing, the efforts is what I'm sharing with you. So the pediatric liver matures into adult liver, and the specialty, that is pediatric hepatology, follows suit and matures into adult hepatology. Does it do this? How far are we from them? How far were we from them when we started off, and how far are we now? Have we actually improved on that gap is what I'm trying to look at and trying to share with you. The gentlemen here, I very, very cleverly used Vikrant Sood, my colleague, to be standing next to the adult hepatologist, that is Professor S.K. Sareen, because Vikrant is the tallest possibly amongst us. So the gap doesn't seem very, very wide. But actually, there is a gap, and we should accept it. Only then we can shorten this gap. So this is a slide by Rajiv, and I must congratulate him on understanding that this is hepatology. This is pediatric hepatology, the etiologies which they look after, the etiologies that we look after, and there are some common etiologies, that is NAFL, Wilson's, autoimmune disease, and there are some advantages that we have, that we understand, and they're actually understanding and trying to take this experience towards themselves. Similarly, their experience, also we are trying to imbibe, and this is how we are growing together. There is, like I said, a widening scope of beyond age spectrum. Again, Rajiv's slide, where all these studies that all these diseases that we had been discussing on day one actually are pediatric, but maybe adult onset of these pediatric liver disease. And a lot of these cases are come back to us from the adult hepatology group. They keep asking us about these diseases, how to diagnose these patients. I feel that this one slide is very important because it tells me, one of my colleagues here, Dr. Chagan, is sitting here, and he helps us with he and other departments help us. His is the Department of Histopathology. We have hepatovirology, transfusion medicine, interventional. You heard Priti Vijay's paper today. Immunology, genetic research. The latest to add to it is the microbiome, which we are now trying to build in. I will be talking about it. So all these specialties associated, also helping adult hepatology to grow. They're also helping us to grow as well. This is one slide that came from Dr. Yacha. I must thank him for this slide. This tells us when did we start the PDCC course as SGPGI, then the DM course as SGPGI, the PDCC course at ILBS, the DM course at ILBS, and then the DM course as PGI. Also, not to forget the Isfagan fellowships at 6 centers, which is now available. So we got inaugurated around this time, 2011. This is former President APJ Kalam. This is how we have been changing. Just one attrition, Dinesh left because he wanted to go and settle down in UK. Not because he didn't like ILBS, but because he wanted to leave the country. I kept on insisting, come back, till you decide that you really want to stay back and you like the job that you're doing. So till he didn't find the job to his liking, I didn't allow his position to be closed down. So this is how we are. And this is how we have fared from the time we started the department in 2011 to now. We have some fun in the wards, but this is the kind of growth that you can see of the patients that are coming to us, whether in the IPD or in the OPD. Fun time and serious times of the convocation at ILBS, and Dr. Vikrant, when he was a student, he was having fun with the students. This slide shows as to what are the students that we have been able to produce. Only 2 DM students, but quite a few, 8 have finished or 9 have finished the PDCC and have reached various areas. These are the current DM students that we have at a department. This is an important slide because I want to show you that we are in close terms with the SGPGI. They're helping us all the time. We are in close terms with PGI. Dr. Thapa has helped us quite a lot. But we also try to build relations with across the border. There's no harm. In Quran, it is written that I have not read the Quran very extensively. It's written, if for knowledge, even go up to Chin. So for them, Chin was too much. So for knowledge, you go anywhere and try to learn. I'm ready to learn anywhere. So this is one center that we have collaborated with, the Texas Children's Hospital, and we do every monthly or 2 monthly, we do a presentation with them. Either they present or we present. So this, and even the adult group joins in. Some of the times they have very important questions, we ask them to join in. These are the various conferences that we have done at our center, which is only help. This is the adult group of APASL, ARC, ACLF, and they had recently done this study where you see Dr. Yachar, Dr. Thapa, and Anshu joined us, and we had this consensus on pediatric ACLF. Similarly, the APASL in March 2018, where a lot of other people had also joined us. I don't have the photographs because the event management people lost all the photographs. So I can only show you the photographs when they came to our center. This is about this is a very, commonly in the last 5 years, we are doing this one event that is called as Clinical Scenarios in Pediatric Liver Disease. I welcome all of you to come and join us there. I would like all of you to even send your cases in, and we can have a discussion on them. What are we doing? Are we also doing liver transplants? Yes, we are doing liver transplants. And I think we are very unique because we are the only DM pediatric hepatology course who's doing liver transplant in the country. In fact, we are the only DM pediatric hepatology course in the country. We are the only public sector pediatric liver transplant in a teaching institution. The only DM program where students are receiving training in transplant hepatology. And also we are unique. I'm sure others are also doing this, but we are actually treating only Indian patients, and that too very poor patients. This is Amir, who wanted to be a doctor. I told him, no, we don't have money. You don't have money to go to a private sector, to private institution. You try and do the NEET test. He couldn't get through. Now he's planning to do biochemistry. I'm happy for it. These are the other small children that you can see. Are we doing liver transplant and all? The mandate at ILBS is do pediatric liver transplant as a last resort. And so, with 14 Wilson's disease children with NWI between 12 to 18 who received HVP, we could save 4 with native liver. The other 4 got transplanted, and for 4, we didn't have an option for transplant. So these are the various reasons why we've been doing the transplant. You see this handsome man here, Rajiv, is sitting somewhere in the background. He is responsible and he does a lot of taking care of our endoscopy unit. The other fellow that you see here is an adult hepatologist who helps us with the EUS. We haven't started doing EUS ourselves. Another handsome man from my unit, Vikrant Sood, he has been trained to do TGLBs and he's been assisting and now even doing individually TGLBs himself. EUS, we're doing with the help of the adult hepatologist. The IR team is doing the tips and the other procedures for us. What all publications? She just showed the publications of my publications, the 74 publications. But out of them, 53 publications we have done from this unit, from this department in roughly 5.5 years, because 2 years, we had a first publication after 2 years of establishing, and about 8 chapters that we have written together. This is the first paper, or maybe second paper that came out, small numbers, ALF in less than 3 years of age, just about 30-odd patients. But the important point was, it was the first time that anybody was discussing MLD in ALF from this country. Then this paper of 109 cases at that time, now we are about 200 plus old. The key points which came out were that for pediatric ALF, it's a poor outcome for indeterminate and MLD, and a poor prognostic factors are PELD at 72 hours to be 24, or the JE interval to be more than 7 days. Another important paper, which definitely is something that I thought of, and later I decided that Vikrant should do it as a study, and then it was published. This was, why is it that all the ALFs, there's so many patients who get HIV. Let's take, for example, HIV and they have hepatitis. But only a small percentage of them have ALF. We just hypothesize that is it something else underlying in these patients? And one such underlying cause could be FAOD, because otherwise just to diagnose FAOD is little difficult. So we tried to look at all 50 ALFs and tried to look for FAOD, and we found in 3 patients it came out to be positive. This is another ALF study that has just been concluded, and as a thesis, the HVP done in children with acute liver failure, and what you see here, 24 in each group, and you see that seems to be helping out in the first day 4 and day 7. It seems to be having more transplant-free survival in days. Another study, again in ALF, where we are trying to look at ONSD and then trying to see if the ONSD change. ONSD is the optic nerve sheath diameter. Does it change with the cerebral edema management in ALF? Rajiv's 2 path-breaking papers. I think these, you cannot understand portal hypertension. It's a reference paper in portal hypertension children. Again, a similar paper in clinical liver disease. And again, the handsome man there, who has a data of almost 82 children at Albius, where he's done the HVPG, 42 with CLD, and the rest were the non-cirrhotics, for which we have done the HVPLG. I think it's one of the largest data. I don't know, Rajiv, what are you waiting for? Another study where Vikrant, as his thesis, has tried to prove that there is an element of family clustering in NAFLD. So if you have a parent who's having diabetes, hypertension, NAFLD, his progeny is most likely to have NAFLD. So this is another paper that we had, and it's got reported in one of the newspapers also. This paper has been discussed very in detail by Dr. Malati, so I'll skip this. This is Vikrant's paper on HBV. The spectrum of pediatric acute liver diseases, and Vikrant felt that 75% of our patients come with actually F4 fibrosis and 90% with portal hypertension, but they still have a good outcome only on medical management. That's what Inshu just said. Pediatric acute on chronic liver failure for the first time, and along with SDPGI and a PGI paper where they had earlier discussed the pediatric acute on chronic liver failure. We also did this, just a descriptive paper. Later, Vikrant came up with this ARC-ACLF score, which has already been described by the adult group, and then he tried to look at the ARC-ACLF score, and we felt that it was actually very effective in telling the prognosis of these patients. And if both ARC-ACLF as well as the Cliff-SOFA score seems to doing a very good job as prognostic markers. We cannot miss this paper. It may not be ACLF, but this is one paper, I think again a path-breaking paper from Anshu and Rishi Bolia. They're sitting in the audience. It shows they have seen these patients from a different view, but they also feel that Cliff-SOFA has a good role to play as a prognostic marker. Acute kidney injury. I was listening to the papers which were presented yesterday, and one of these papers where the student was talking about acute kidney injury and resistive index. So here again, acute kidney injury, we know causes 7.7 folds more chances of death in patients with ACLF. And Vikrant tried to show this therapeutic window where an early targeted intervention can help prevent AKI. And if AKI has happened, early therapy can actually improve the patients even from AKI. So this is what is required here. Again, we have planned a study with other biomarkers to detect AKI early. This is Preeti Vijay's thesis. HPS in biliary atresia versus CLD is what Snehvardhan has just submitted. And it seems that biliary atresia is developing HPS much earlier than the other causes of CLD. And another very important thing that we have, I think Neelam should note this, is that we have taken the criteria of AA gradient O2 to be age appropriate, and that increased the prevalence of HPS in these cases. Maybe other centers can also try and see this. This paper again from SDPGI, where they had looked both at the cirrhosis and AHPVO, and they did with the criteria 1, and their data, their percentage of 40 and ours is 41 was almost comparable. A weekly regimen of vitamin D versus the STOS regimen. Vikrant came up with this data with the RCT and described how staggered doses are well placed in patients with CLD rather than the STOS. And the reason is fantastic, which I think he is a very brilliant pediatric hepatologist in the making, and he discussed with me that, madam, is it that this weekly dosage is actually the two rate limiting factor in these cases is possibly the portal hypertension causing the enteropathy, so the absorption of vitamin D is not good. The other could be the change of or 25 hydroxylation of the vitamin D, and both these rate limiting factors can be removed once you do the weekly dosages. Nutritional assessment, this new tool of subjective global nutritional assessment works very well. It tells you even about what is your patient going to be like in the next 1 year. So you can prognosticate the family and you can manage his and plan his management as well. I think this is one small study from the biliary atresia group, and we felt apart from other causes, it was use of steroids that we have seen seems to be working well. It's a small study. We need more data on this study. As far as pediatric, the progressive familial intrahepatic cholestasis is concerned, we've published one small paper, but recently we even picked up a FXR mutation in one of our patients. Transient elastography. Rajiv, again, I tell you that this is one excellent data that we have. He's looked at the ROC curves for transient elastography in fibrosis as well as in cirrhosis, and the cutoffs are 16.15 and 23.5 respectively in the two groups. And this is, of course, in the NCS group. This data has never been published anywhere. Again, he tries to look at GGT and transient elastography and tries to see if biliary atresia versus NCS, can these two things help? And they feel that in children less than 0 to 3 months, it's GGT which helps better. But in children beyond 3 to 6 months, it is transient elastography which helps. And so you may even avoid a biopsy if you're not planning a Kasai surgery in that patient. Okay, so this is the recent 2 patients of ACLF who we gave HBV reactivation, who we gave 2 antivirals. They didn't help, it did not improve, so we even tried fecal microbiota. And like you can see, the INR improved, and the bilirubin also improved. We are still going about with these patients. So I will not say they are saved from liver transplant, but they seem to be doing well right now. The various awards that we have picked up: ISFAGAN 2018, ISFAGAN 2017, APASL annual meeting 2018, AZLD 2017, MCLD 2017, APASL again annual meeting at Shanghai, thesis award for Vikrant, and of course ISFAGAN has been there for us, and we've been bagging awards here now and then. These are just protocols that we follow for MLD, based on which I was talking about all this in the pre-conference workshop that happened. So I'm not going to go into details of this. These are the various protocols for MLD, suspected MLD in various presentations. And we use them, but we need to validate it, and we are trying in the process of doing that. This is one thing that ILBS was doing initially for SCV patients. Adult hepatologists were there. They're looking at they extended it to the decompensated CLD and ACLF, and then pediatric hepatology joined hands. Rajiv went and gave a lot of, I think 3 lectures to various medical colleges on CLD. I've taken 2 lectures on ALF, so we are also joined hand. This is a community outreach program, which again is a very important thing to do. interpersonal relationships. I think this is a very important thing in a department. I learned this from a man who's sitting in the front seat, Dr. S.K. Yacha. He gives you a smile for every problem that you've taken to him. And that's what I felt was the most important thing to do. And what you see below as a message, this was the WhatsApp message that I got from Dr. Yacha, and I took his permission to allow me to share it with you people. But for me, this is a testimonial. I don't need anything else beyond this, because this is what is the most important role that you can play as a leader in a department. And are we on the right path? Yes, I think we are on the right path. Where do we go from here? I think this is one slide that the secretary as well as the president should make note of. We need research grants, of course. We need research grants for our cities. We can't just have descriptive studies going on. We need our cities to make a dent on the kind of practices clinical practices that we are following. And we need to now invite basic sciences. We should have a session on basic sciences. Only then we will be taken as a group. We need to not just be having a big quantity. We need to also go down and have quality and depth. This department of PGI Chandigarh, every time I'm in need of some problem or the other, Dr. Thapa has been around. This was established by Dr. Saroj Mehta. I never met her. It's my bad luck. Dr. Thapa has definitely been there right from the inception of the DM the DM program was started in 2015. They already passed out 2 students, and total students enrolled right now are 5, yearly intake of 2. There are 2 students, I think, are sitting here. I've met them. Rishi Bolia, Sadhna is heading the department right now, and Rishi Bolia has recently joined this department. Best of luck to you both, Sadhna and Rishi. Take this department to heights. That is what is required. This department is the anchor. This is an anchor. I have turned around to Dr. Yacha. I have turned around to Anshu, the lady sitting there with a sweet smile. I've always had solutions to my problems. Moinak is a very bright chap as well. They have had 36 centers where their students are right now working. 36 centers, that's not easy. I'm so impressed. My eyes, I feel this is just the dream department to have. Rajiv, look at their endoscopy unit. So impressive. This should be our dream as well. Finally, I must thank my Isfagan family. The names are there. Somebody whose name's not there, don't think you've not helped me. You've helped me in some way or the other. There's some people who've helped me. Dr. Malati, every time I've given a worst of presentation and she's patted my back and said, you've done very well. So for the next presentation, at least I'm improving. So this is the way you can build up within the family and also in the Isfagan family. That's what I've seen. There are a few people who, across the border, who have helped us build up this department, and I must name them: Professor Anil Dhawan, Sanjay Bansal, Tamir Milo from the Texas Children's Hospital. Within the country, my first professor, Professor Hussain Ahmed at AMU, who told me, beg, borrow, or steal, but do it for a poor patient somehow or the other. I keep that very close to my heart. Professor Bhan, Professor N.K. Arora, and Shinjini. Shinjini was such a good friend. She's the one who actually pushed me from diarrhea towards pediatric hepatology. So I'm indebted to all of them. And of course, I'm indebted to this department, to Professor Sareen, who's a very good mentor, definitely very good mentor. And like Rajiv put it in this particular slide, difficult pathway, but many more peaks to conquer, and we do them together. Thank you.